share my screen 1 second.
Yeah, we can see it.
Okay. All right, here we go. So I'm George Melikian. I'm an infectious disease physician. I'm also trained in infectious disease epidemiology and also a professional statistician and involved with this epidemic. So I'm going to go over some slides. Here's the first slide, which is actually a bit of good news. This is a graph of all-cause mortality from 2015 to 2020. I don't know if you could see can you see my mouse cursor when I'm pointing to something?
Yes.
I wanted to show this is for 2020, and this is, I guess, this one silver lining of the quarantine is this, or we have an unprecedented low death rate this year compared to other years. So a little bit about, very briefly, I'm not going to get very, very technical, a little bit about coronaviridae. They're single-stranded, single-stranded RNA viruses that are enveloped. They're in this family right here. Close relative to, I guess, what most may know is the retroviridae, which includes HIV. The reason it's called a coronavirus is the virus itself has these what are called spike proteins, which resembles a crown, which the word corona comes from, or the corona radiata of the sun. So these spike proteins play an important role because that's what the virus uses to bind to the host, to gain entry into the cell. They're believed to cause a significant amount of disease in humans, mostly benign upper respiratory infections. In bats, where these viruses are the most common, one thing I wanted to say take a step back. The primary reservoir for this family for coronaviridae are animals, and bats are the most common one. And in bats and other animals, poultry, birds, they cause a lot of diarrheal disease as well. This is an important slide. I know it looks technical, but this is really up to not including COVID-19. These are all the human coronaviruses that we have. You could see up here the alpha-viridae and the beta-viridae. SARS and MERS, you probably heard of. These caused two very large pandemics in 2003 and 2012. This NL63, by the way, when it says HCOV, that means human coronavirus. So this Netherlands 63 strain, which was discovered in 2004, I want you to keep that in the back of your mind as we go on. This is a very common virus, very, very common, mostly among children, and it causes a very mild cold, extremely mild. You may not even know you have it. The things I wanted to point out in this slide, which I'll come back to later, is where they attach. Remember, this is the ACE2 receptor for the SARS and this benign Netherlands 63, which is the same receptor that this current virus attaches to. And I'll explain why that's important. The other thing is the host, this column over here where they come from. Bats, the palm civet, which is this mammal, cattle, mice, camels for the MERS, that's the Middle Eastern respiratory virus. So you could see this as kind of the background. The 2003 SARS epidemic resulted in 8,000 infections. The case mortality rate was 10%. This one was, again, from China, almost identical to this in the sense that the host went from bat to civet to humans. And then in 2012, the Middle Eastern respiratory, the MERS epidemic, that was 803 deaths, 2,260 infections, and a 34% case fatality rate, much higher. This is a little bit of a summary of the 2003, but this is actually just about identical to what is going on now. And this isn't just my opinion. This is actually, there's been several papers that have been recently published. A big one in Nature that looked at the evolutionary, uh, the phylogeny of COVID-19 and really traced it back right down to the civet and the bat. It's not clear whether the virus went from bat to civet to human, or went to human and then to perhaps wasn't fit, went to the civet and then went back and forth and then came back. We see these kinds of jumps a lot in infectious disease. For example, the avian flu with influenza, where people, this really came about where people were keeping birds and pigs very close to one another in China. And the pig, if those of you who are scientists will know that we do a lot of the immunology research that we do, we use pigs as our model organism, animal. So in that case, we had from ducks, the influenza jumped to pigs, and then in the pigs, it became better adapted and then jumped to humans. This is called a zoonosis. So again, like SARS and MERS, this is a novel virus. It's absolutely brand new, and it causes both upper and lower respiratory tract infections. The upper respiratory tract infections are very mild. That's what a common cold is. Lower respiratory tract includes the insides of the lungs, and that's what we talk about when we talk about pneumonias and all the serious infections. We also see some diarrhea, gastrointestinal disease with this infection as well. We all know this. I won't dwell too much. We know the human to human transmission. It's also important to note that the coronaviruses, including this one, can survive on surfaces for 3 to 9, in some rare studies up to 28 days, but I think functionally 3 to 9 days. Here we have 8 days. I just said that transmission occurs. I'll come back to this here in 1 second. Typically, after somebody is exposed, they won't have any symptoms for, on average, 5 days. That's called the incubation period, from the time between exposure to when you start having symptoms. The maximum, or the 99th percentile, this is based on actual data, not opinion, is 14 days. So that's where the 14-day figure comes from. This was a study that was recently published in the Annals of Internal Medicine, when they looked at all the data. If somebody waited 14 days and still did not have symptoms, the possibility that they were infected was less than 1%, but on average 5 days. It is also becoming more and more clear that patients who are infected are shedding virus and are infectious probably 48 to 72 hours prior to when they have symptoms themselves. They're not aware that they're shedding virus. This is actually let me just move this thing here. This is from that paper I was just telling you. Oops. I don't want to dwell too much into this, but if this is, 1 second, sorry about that. Very sensitive for some reason. So if you look, this is the 50th percentile, the incubation period, what I was talking about, 5 days. 75th percentile is about 7 days. 97 percentiles, that's where we get this 14-day window. And this is based on data from several locations. What do patients often experience? Number one is fever. And if you had to really classify this infection, it's an infection of fever and dry cough. If you're having a runny nose, it's not likely that you've got COVID. That's more common with the common flu. But fever that stays, that undulates, cycles back and forth, but it doesn't go away, dry cough, and then fatigue, myalgia, things like that, these also come and go, but they're not as reliable, I think, as fever and fatigue. Here's another slide basically showing the same things: coronavirus, cold versus flu, influenza. And I would say there's rare on this diarrhea. This slide came out early. More and more we're seeing there is a significant portion of folks who have diarrhea when they come in. So ignore maybe this one. But rare runny nose, sometimes aches and pains, no sneezing, but usually a dry cough and a fever. This data is from the original from the WHO based on about 44,000 infection cases. Death rate for confirmed in all cases. The reason this is important to point out, which many people maybe didn't know or may find shocking, but the risk of death from if you have a pre-existing cardiovascular condition is actually higher than if you had a respiratory condition or even cancer. That's a very curious finding, and I'll explain for a little bit later why I think that's going on. But this is definitely different than what we see, for example, with influenza. Cardiovascular disease isn't usually a risk factor for death for respiratory viruses. This we know: wash your hands, use mask surfaces. Brief summary to where we've come so far. Well, we're way past 210 cases worldwide. Infection epidemic started in China. There's no current treatments or vaccines. There are some experimental medications, which we'll talk about later. I won't belabor this slide. Who's most at risk from dying? This is based on 44,672 confirmed cases from China. The risk of mortality for those 80 and above, you could see, is 15%. And it drops off pretty precipitously. For those 50 and younger, it's less than 1%. This data was, I'll come back to this in a second because this data has been explored in a number of ways, and we have a better idea of what that is. This is where we are as of today in LA County, 3,000 cases with 54 deaths. Those of you who are in Glendale, please take this seriously. This was published in the LA Times today, I believe. Richard Ohanian sent this to me. 76 confirmed cases, one of the highest cities in the county. So again, I don't want to make this into a big lecture. My point is to get through these very quickly. I don't have too many slides, so I can open it up really for questions. It's probably more useful than just tables and figures. But these are some important points. This slide where I wanted to show is the question of testing. People wonder when we go to get tested, and I test positive or I test negative, how accurate, how reliable is that test result? We don't have a whole lot of data. This was published in JAMA recently. There's still data is coming, but we don't have a whole lot of data. What I wanted to show you is this. This is the sensitivity. This is the percentage of folks who had a positive test result from known cases. So from the sputum, that's the mouth, the sensitivity was 72%. If they do, they'll usually put a Q-tip into your nose or into your mouth in the back of the throat. From nasal swabs or pharyngeal swabs, it was 32%, nasal swabs, 63%. What I wanted to point out is look how low that sensitivity is. It's not 100%. Of course, this is bronchoalveolar lavage fluid, that's fluid from your lungs. If you end up getting intubated or they go in, that's a very invasive sample, nobody would do it. But then it goes up to 93%. In practice, what does this mean? It means if you have a positive test, you can definitely be sure that's not a false positive. However, if you have a negative test, it's important, and this is what all the doctors are doing, is to consider it, not take that test result as the word of God. It could be a false negative, and to really follow the clinical picture. If you're still having symptoms, if the picture looks like it's COVID, we'll usually retest. If you're in a group, a high risk group, we'll retest and treat it as COVID regardless of a negative test because the sensitivity is fairly low. The next few slides, I want to talk a little bit about the epidemiology, the data. And I'll explain. This may be a little dry or uninteresting to some of you, maybe not. So this is a common graph, what we see, right? Everybody's seen these kinds of figures comparing countries. We're comparing cumulative number of confirmed cases on this y-axis and the date here. So this is actually wrong. I know it's very popular. It's wrong because we can't compare from one country to another or one city to another. they have to be divided. What really we do in epidemiology is we have to use what's called the attack rate, which means you divide the number of new cases, but in the denominator will be the number of susceptible people in the population at the beginning of the period. So it's like basically comparing somebody who loses 60 pounds of weight if the person weighs 120 pounds to start, or if the person weighs 420 pounds to start. It's not comparable. However, it's bizarre because every epidemiologist knows this, and it's not very common to find. So if these numbers are adjusted, we can have a better idea of comparing these figures from one country to another, and we're not quite there yet. The best data that we have came from this Diamond Princess cruise ship outbreak, where everybody on this ship there was the outbreak of COVID was on the ship, and everybody was isolated, and they tested everybody. So there's two things to know. There's folks who were infected who had symptoms. There was folks who were infected but had no symptoms, and of course there's folks who were uninfected. And that's the difference here between this IFR means infection fatality rate, and CFR means case fatality rate. Case fatality means this is a confirmed case where somebody was symptomatic. Infection fatality is a broader category, which means it may not be a confirmed case. Somebody has the infection, may not have symptoms. The reason I'm showing this slide is in the community currently, I think what everybody's beginning to realize is that these are very accurate numbers, the case fatality rate that we got from this cruise ship data. But this is really what the underlying case fatality rate is, and that is it's about 1.9% of those infected who are symptomatic, and if you kind of broaden it to include folks without symptoms who may be infected, it's less than 1%. If you break this down by age for those 70 and above, the number goes up to 14% and 18%. This truncated and non-truncated, I can explain. It's a little bit technical, but essentially this is what it is. When you look at the figures every day and they tell you this is how many deaths we have and this is how many cases we have, how many infections we have, you can't simply divide the deaths to the cases to get the rate, the proportion of cases who die. Because there's also obviously there's a number of infections who will die, let's say in the next 2 weeks, and those haven't been figured into the calculation yet. On a crude level, you can do that, but the truncated calculation accounts for that. And it's a complex mathematical calculations using this thing, survival analysis and right censoring, but roughly it's more accurate. That's why it has a higher estimate. This includes the truncated values are a little bit higher than the non-truncated because they are accounting for the cases that likely will die next week and the week after. So this brings us to another question that people often have is, well, how many cases are there? Because the more you test, the more you find, and we're rolling out testing. So just the number of infections, number of cases that you see, that doesn't represent how many infections there are out there. Well, there's actually a very clever way of figuring this out to see what the actual number is because of underreporting. The way to do it is you back calculate. So if we assume that if we can trust the mortality, the case fatality rate, like that I was showing you in the previous slide from the cruise ship data, we can back calculate and say we're expecting 1.5% on average. This is from a paper that actually did that. We are assuming 1.5% of those infected will die. And this is the number we're seeing now. And based on that, if you divide that figure, you can back estimate, well, what percentage of cases are being reported. Currently, using these kinds of metrics, the estimate is in America, it's 15% of the cases are being reported. So the actual number is multiply that by 1, 2, 3, 4, 5, 6, 7 times, 8 times. Okay. Let me just see what we have here. Okay, and I'm almost at the end of this talk. I wanted to remember in the beginning I talked about those two receptors. So this is the last thing I really want to talk about. This is very this is actually my theory, but I think this is very interesting. So this Netherlands 63 strain of the coronavirus is very common. It's floating around, and this is from a Brazilian study that looked over 7 years, I believe. And this color here, the NL63, is how the detection frequency of this virus in different age groups. And you can see in the 0 to 9%, in age 0 to 9, it was 70%. And it just steadily drops off up to age 60 or age 59. And then if you look at it, anybody greater than 60, no cases at all of NL63 were detected. And this is when I say detected, they looked at serology. They looked to see if anybody had antibodies to this virus. Why is this important? Well, this NL63 attaches to the same receptor as COVID does. It comes from the same actual reservoir and background, the bats and the palm civets, as COVID does. This was discovered in 2004. So if we go back here, this would explain, my theory is I think what's happening is I think there's some cross immunity between the Netherlands 63 strain and the COVID strain that's going on now. How else can you explain that this virus is basically leaving children untouched? Absolutely untouched. It's very, very rare, if at all, to see any young children sick, very sick, in the hospital sick. They may just have a slight flu. However, those who are older who weren't exposed to this virus, this has, I think, very important epidemiologic ramifications. And perhaps I think we'll know soon, once we can do some serology to see if there's cross-reactivity, or if people have antibodies, the folks who were very sick with COVID had antibodies to Netherlands 63 or not. In an ideal world, you could probably, perhaps I was thinking, if you could give somebody this NL63 because it's so benign, if it can confer cross protection. By the way, this is something that happens with other infectious diseases. It's called viral interference. And when your body fights off one type of virus, and it's also the same with malaria, it confers resistance or immunity to related viruses. So this is something to keep in mind. And that's it. I won't go into this. This is about treatment with steroids or not, and some of the other data. So I'll just open it up from this point forward if anybody has any questions.
Thank you, Dr. Melikian. That was very informative. We do have a question that came in from Shante. She thanks you for your time, by the way, and her concern is with the projected airborne capabilities given mounting evidence of aerosolization lasting for 3 hours airborne. Is it like perhaps those walks people are taking are ill-advised and exercising at home is the best option? What do you think?
So the 3 hour aerosol, it's not that it's hanging around in the air for 3 hours. I think that's a little bit of an exaggeration. I know which one you're talking about. If it's really most for a closed room situation. Now it's true. In China, COVID was found in the vents, was recovered from the vents in hospitalized patients. So that says a lot actually about the virus, that the virus, floated up. The guy probably sneezed in the room and it went up and traveled. But I would say is when it comes from day-to-day living, if you're outside and walking around, it should not be a significant issue. Closed room different.
Okay, we have another question. How accurate is the calculation on when the virus peaks within a country or city?
I don't know how to answer that specifically. It's accurate in the sense not a single measurement is accurate, but once the epidemic hits an inflection point where you go over the hump and you start seeing a trend, that's definitely reliable. there's this thing called Farr's law, Farr, that is one of these consistent patterns that we see in epidemics. And that is that the onset and offset, the way an epidemic comes on and goes off, is often symmetric. It's like a bell curve. And it's a very reliable calculation, and many epidemics, looking backwards, people have gone and studied them. They always follow that distribution, that law. The reason that's important is, well, a number of things. One is you can use it for those of you who have mathematical backgrounds, you can, using current data, incidence data, you can generate a normal trajectory, a moment, and try to predict where an inflection could be. But more importantly, also, once you hit an inflection, once you're on the way down, it's very simple, actually. It's very intuitive. You can just flip the curve, where you went uphill, just flip it over a mirror image and make it. That's what the epidemic will look like. It will be a symmetric carbon copy of what we went through on this side.
Okay, and two more questions. One is.
Can I add one more thing, if I may, very quickly before?
Sure.
A good way of thinking about this epidemic is, because I know I'm talking to scientists and engineers, it's like a reaction. It's a fire that's burning, and it needs basically food, it needs energy for it to keep going, and the energy is hosts. So every time, once it infects somebody, if it doesn't transmit itself to somebody else, the host will either die or become immune. Once the host is immune, then it can't, that virus is gone. It can't survive. So basically, it's like the fire burns out. So it's a function of how much firewood there is, how many susceptible hosts there are, and at some point it will run out of hosts to infect, and it will die off. Go ahead. Sorry.
Okay. The other, I guess this is just tying to the very first question regarding the airborne. New York City is extremely densely populated, and lack of shut-in enforcement means that people are in the streets, parks, and out all day, every day. Is there any suggestion from you?
As far as to avoid places, or what's in what context?
Well, like with the airborne
Precautions.
Should the people stay home and not encourage them to go out for a walk?
Well, New York's a very different situation because it's so dense, so I would definitely exercise caution in New York going out. If you can't be 6 feet away, it's hard. I went to medical school in New York, so I know you can't be six feet away from anybody in New York. But I wanted to also emphasize is the respiratory, the airborne portion is important, but also keep in mind a very large proportion of the infections are also coming from people touching a surface where there's virus and then touching their face. And we do it. I just did it 10 times, probably just talking to you. Keep in mind, be very cautious, keeping your hands clean, touching surfaces. If you imagine what we're talking about, the virus could survive on surfaces for 3 to 9 days. An airplane seat, a subway, banner, or whatever that is. These are basically petri dishes. So.
All right, thank you. Another question is, do we get immunity to the virus once we get infected?
Yes. There are very rare cases. You may see the press will probably sensationalize this and say, oh, there's another person who was infected twice. But for all purposes, this is you have 100% immunity once you've had it, if you get through it.
Okay, sounds great to me. Maybe I should get it then. Another question is, could you talk about treatment, the 2 medication combination that some recommend?
Very good question. I'm glad you asked. So as far as treatment goes, I between me and also some of my colleagues at different hospitals around the country, we also keep in touch and talk about patients who we have plenty of patients on therapy. As far as options for therapy, right now it's that hydroxychloroquine and azithromycin together. Azithromycin, which many of you may know, is the same as the Z-Pak that we use just to treat common upper respiratory infections. That antibiotic also has anti-inflammatory properties. It blocks this called IL-6, interleukin-6, which causes a lot of inflammation, which is very pronounced in this infection. So the protocol is to use both of them together. There's the data so far is all anecdotal. You know, we're going to have very good solid data here very soon. I know there was the French paper, the French study that came out, and it was an open label study. It wasn't the best, most rigorous study. Let me just, I guess, cut to the chase. For the time being, I think it's a very reasonable choice to make. We're not seeing negative effects from it. I can personally say, I mean, this is just based on what I've seen, is I've seen fairly good results with folks who've been on it. People who I noticed were short of breath, have high oxygen needs, running fevers, and you start the hydroxychloroquine, and within 24 hours the fever stopped. Now it's hard. Again, this isn't science, because how do you know they weren't going to stop? The fevers wouldn't have stopped anyway. It's just, I mean, you just don't know. You have to have more data to compare. But for the time being, it's what we have, and I think it's worthwhile. The most important thing I wanted to say, and this really goes towards people who are in those high risk categories. First of all, I'd say trust the 1 to 1.5% mortality rate. It's not going to be higher than that. And viruses rarely, if ever, they don't evolve towards more virulence. They don't. It's not like next month it's going to start killing 30% of its host. That won't happen. But folks who are in the high risk group, really, what you saw in the previous slide, these are patients or people with underlying cardiovascular disease and advanced age greater than 60 years old. If you're having fevers and a dry cough, the important thing is to go in right away. Don't delay it. These antibiotics, they work in this initial phase. So what happens is after the infection, for about 9 days, patients have fevers and all these symptoms. This is when the virus is basically just replicating in your body. Around the 9-day period, the 9-day mark, if somebody is going to crash, is going to do very poorly, that's when it happens. It doesn't happen on day 2. So you shouldn't expect, like, today I have a fever, tomorrow I'm going to end up on the ventilator. If that's going to happen, it'll happen about 9 days in. But the important thing is these antibiotics, all of these things, if they're going to work, they work if they are started early. Once somebody goes into what's called ARDS, that's what that respiratory syndrome is, acute respiratory distress syndrome, where you see patients on the ventilator. The antibiotics are now very effective. They're actually not effective even when we have patients with pneumonias with bacteria, that we know what the bacteria is and we have antibiotics for it. We can pour it on, but once they're on the vent, it's just like a process out of control. So long story short, if you're having symptoms and you're in those age groups, I would suggest seek care early and get started on this medication empirically until we have some results back. Don't leave it for later. There's other medications too. This medication called remdesivir from Gilead. This is a medication that was developed for Ebola, and it didn't really work out very well for Ebola, but it's very promising, and it's in large-scale clinical trials right now. The good news about remdesivir is because it went through at least to phase 2 clinical trials for Ebola, we know its safety profile, and it's relatively safe. It's actually a very safe medication. It's the question of how effective it is. Nobody has real data so far, but we have a lot of anecdotal data on patients who've been on remdesivir, and it is showing promising signs. And I'll also say this, given the number of trials there are out there right now, and compassionate use, that's the thing, we can call Gilead if somebody's sick and ask for remdesivir. The fact that it hasn't been pulled, because these, the statistics are followed very closely by independent review. The fact that they haven't pulled it and said, no, this is not working, it's hurting, is very hopeful. That means I think that it's reasonably effective. Those are the 2 main ones. Then we have some other medications that we use in case somebody ends up on the vent, which are for the inflammation, but not the infection. But these 2 right now, I think is all we have. Not I think, this is all we have right now.
Okay. Thank you, Dr. Melikian. Another question we have is, usually symptoms show all at once, or having fever considered you have the virus?
Can you so if you have the fever once, or you're saying if it continues? I'm sorry.
Well, the question is like, do all those symptoms that you mentioned, do they all occur at once? And the second part of the question is, or is having the fever considered you have the virus?
They usually occur in the syndrome. They occur together. So what you'd notice when you're sick, you'd start having a fever, you'd feel weak, and you'd have a dry cough. They come on together. And here's a dry cough right there.
Bless you.
And the thing is, it just doesn't go away. It doesn't go away for 24, 48 hours. It'll just stick around. And if that's going on, it's important to seek care. I want to add, not everybody who has a fever and a dry cough, that doesn't mean you've got COVID. The important thing is to get tested to rule it out. For example, influenza, which we're still in season for, presents exactly the same way. But it's important to keep in mind the fever is very important. If you don't have a fever and you just have a dry cough, it's not likely that you've got COVID.
Okay, thank you. Another question is, can you comment on Imperial College's prediction of a second peak in the number of infections around November? What, from a public health perspective, may reduce the size of the peak?
What the Imperial College, that it said, what was I didn't know what specifically, that there was in last November, that there was the size of the peak of the initial epidemic?
Let me see if I'm assuming it's for the upcoming November. I don't see anything in there asking for last November or details.
I'm sorry, I don't know. I haven't, so I'm not familiar with the Imperial College. I can comment on the seasonality. So because people ask, is this a seasonal infection or not? In fact, it's not entirely established, and I wouldn't say for sure this is going to be a winter virus, because the other viruses in the Coronaviridae family have not behaved as predictably. Like influenza, for example, that's seasonal. I think we will know very soon, but there definitely seems to be a temperate, like a common temperature distribution where this virus is thriving right now. But I think we will know in about 2-3 months. So I wouldn't put. I'm not saying it won't be. I'm not convinced at this point.
Okay. What temperature considered fever for this specific virus?
38.0, 100.4. 38 degrees Celsius or 100.4.
Okay. Is the virus killed by the heat?
You mean outdoor heat? Yes. Yes. I don't have the exact number. I think it's like 110 degrees or something. I honestly, I don't have the number off the top of my head, but it is killed by heat. But that's not the way to kill it. Really, it's to use soap or alcohol. Detergent is really the best way to get rid of it. There are some crazy ideas. Somebody sent me somebody putting a hair dryer into your mouth, and supposedly that doesn't work. Don't do any of those things. You'll burn out your lungs and have all sorts of problems. So.
Yeah, definitely not gonna try that one. What is different between mad cow disease and COVID-19? The mad cow disease, the virus was among the animal, and COVID-19 virus is among the humans. How are those viruses attack their target?
Oh, they're completely different. Actually the mad cow disease is a prion. It's actually in its own family. It's not really a virus in the classic sense. It forms these. The way it replicates is it forms these crystals or spongiforms called BSE, spongiform encephalitis. This is a virus where it attacks a cell, it injects its RNA into the cell and replicates itself. So not related at all. That one was passed through. You're correct. It was a zoonotic transmission from animals to humans by eating the meat that was infected with. But that infection is extremely rare and completely unrelated to coronavirus.
Okay, I think there's not the question that follows up, but with the hate question, if the virus is killed by the hate and if it stays on clothes, that was another part of the question.
Correct. So I mean, it's known. It's been studied. It does stay on cloth and surfaces, and it's killed by heat. So It does.
Okay. Another question is about the immunity. Let's say one gets the virus and recovers. If the virus is mutated later on, would that person be still immune or not?
We will know. I think we will know shortly. This family of viruses doesn't go through the same. It's called antigenic shift and drift. That's what we see with influenza every year. You have these major changes in their antigen structure. Basically, their code, their lock and key that your body recognizes. It's not clear whether this virus will undergo that. For example, other similar viruses, what I talked about earlier, the SARS, the 2003, and the MERS, we don't see those anymore. Those are gone. They're out of the picture. They're not coming back, new and different. So I don't think, if you want my off the record opinion, I don't think that's something that we really have to worry about. I don't think that will happen. For sure, once they go through this infection, they will have recovered and they will likely have immunity to similar, similar viruses. And I'd venture to say that being infected with that Netherlands 63 strain probably confers some immunity, and that's why we're not seeing it in children, which is very curious. That graph. I mean, that's so interesting that we're not detecting any exposure to that virus for anybody above 60 years of age, and exactly that's the age where we see the very serious infections with COVID. I think these things and we've seen this in other viruses too. We'll have the data very, very shortly.
Okay. Well, you kind of just answered the question, but another question is, will you please explain the reason why kids are not good hosts for the virus?
Yeah, it's likely because they've been exposed. Their immune systems are more current. We know, immune systems or people's antibody profiles, they wane with time. They get poorer and poorer if they don't see the same. And also that, for example, that Netherlands 63 strain, which I showed you, was discovered in 2004. So that's when those kids were exposed. So older people over 60 may have not been exposed, for example, to that strain when they were children.
Okay. Since we built immunity to COVID, are we closer to testing antibodies and allowing people back in the society because of herd immunity?
Can you repeat that one more time?
So, since we built immunity to COVID, are we closer to testing antibodies and allowing people back into society because of herd immunity? Herd?
Oh, herd immunity, because of herd immunity. Well, it's not. I mean, we don't formally test people to allow them back. I mean, herd immunity is herd immunity. I would actually even argue in having children go to school would be beneficial because they would act as herd immunity. They would be infected. They're not going to get sick, and they're a barrier. A virus infects them. The fire's not gonna burn any longer. Of course, the worry is that they come home and they infect somebody elderly. But to answer your question, it's not like we're going to test people to see if we can, send them, they're okay to come back to society using an antibody profile. The idea is to just really wait until this fire, like I was describing the analogy, it really kind of burns itself out. It constantly, these viruses, they need hosts to survive. And when a host dies, the virus dies with it. And when the host is immune, the virus dies with it too. And for sure, everybody who's infected will either be immune or unfortunately, they will die. So it constantly needs, it's like a Ponzi scheme. It needs new hosts. So the idea is if we just wait, that's what we're trying to drag this out a little bit, but to wait for this to settle down and hopefully die out.
Okay.
If that makes sense.
Yeah, it does. So another question is, any comment if we should use vitamin D or colostrum boost immunity against this virus?
Not vitamin D or colostrum. I could, people that talk about vitamin C. I'm not up to date on the benefits of vitamin C. I could tell you for zinc, for sure, there's plenty of, hard scientific evidence showing that sucking on a zinc lozenge improves your body's ability to clear viruses. This is This is a known thing. It's been studied for multiple other viruses. So it has to be the kind you let dissolve in your mouth, though. It's not something that you swallow and goes into your stomach because it's inactivated by stomach viruses. So if you ask me what to do, I do it myself. Every day I come home, when I come home from the hospital, I take a shower and I put in a zinc lozenge in my mouth. So that I think does work.
Okay, I'm not sure if we answered this question or not, but I'll repeat. Do we know how this virus may affect or trigger an onset of autoimmune diseases or chronic diseases?
We have no evidence of that. So there isn't. It's too early to know. So the point being, there are some viruses. It's been postulated. There's some evidence, for example, for type 1 diabetes. The idea is that in certain kinds of type 1, not obviously all of them, but that in the process of fighting off a virus, the body makes antibodies that accidentally will, attack the host, and that's what will cause an autoimmune disease. There's no evidence that this causes any of that, but it's too early to know. I wouldn't expect it, but we haven't seen that with SARS, with MERS, or any of the coronavirus. We don't see it with influenza, so I wouldn't worry, a whole lot about that.
Okay. Can you comment on Japan's numbers? Tokyo and Osaka have pretty dense populations, and despite any kind of lockdown up until 4 days ago, they seem to be handling the virus pretty well.
That's an excellent question. That's a wonderful question. I've been thinking about that too. I don't have an answer for that. I honestly don't have an answer, but I think that it will come soon once we look at the serology. Singapore is another case. I'm not convinced. I don't think that we can account for those incredibly low numbers just based on social control alone, meaning people being very conscientious and wearing masks and all that, because this virus is extremely infectious. I think it's a combination of host factors and behaviors, societal issues, but I don't know the answer. That's a very good question.
Okay.
If I can add, how infectious the New York cluster, the original New York cluster of infections. I don't know if many of you probably know this. It was a lawyer who went to a bar mitzvah over there, and that one person infected, I think it was like 130 or 140 people.
Like in Armenia, huh?
It's like going and kissing, hugging everybody. It's an incredibly infectious virus. Yeah.
How long does the virus stay on clothes?
Let me just remember. How about when we finish out? So I don't want to just say a number out loud. It's probably something around 2 or 3 days. But I have the paper here. I can check.
All right. Another question is: any known reason why men seem to die at a higher rate with COVID-19?
What could die at a higher rate?
Men.
It's likely that because men have more of the underlying conditions than the females do. The cardiovascular disease. So one thing I wanted to say, which is related to this, that receptor, I don't know if you remember, I showed you, said ACE2 receptor. That's what this virus binds to. Some of you who may have, for example, high blood pressure may know you're taking a medication called an ACE inhibitor. And that's the same enzyme. So this ACE, which is angiotensin converting enzyme, it's involved in your body's regulation of blood pressure. That's what the blood pressure medication does. It blocks a step in that process. This virus binds to that same receptor, and it's estimated, or it's very likely that what it's doing, the reason we're seeing so many people who have underlying cardiovascular diseases, is because their system, their cardiovascular system is already out of whack, and this virus really just pushes it over the edge.
And mostly men are the smokers, right?
Men are the smokers. Men are all high risk drinkers. All the bad behaviors. It's all in men. So we're the first one to take it.
I'm having a hard time convincing my dad to not leave the house at all. So good luck to me.
Please, if I may add one more thing, please take these. I know people, I've been told by a lot of people, like, why are we doing this? This is so severe, the lockdown. My suggestion is that really to take it seriously. A lot of these efforts that we do when we're dealing with something that is growing at an exponential, is replicating at an exponential rate, the actions that we take now, we won't see the results until several days or maybe weeks down the road. It's not like right away we do something today to a change in behavior that we'll see the results. So it's the nature of the mathematical relationship. We have to go to be able to get ahead of this thing. We have to kind of go overboard, and then we'll see. And it's very hard. Often epidemiologists, public health people, get nailed for these things because in the end, when everything turns out okay, then it's easy for people to turn around and say, well, see, this wasn't that serious. We didn't need to do all these things. Because it's hard to prove, to show, well, this is what, by doing this, we stopped it, because you don't have the other results. But I would suggest to really take it seriously. I think it's valid.
No, that's because we're impatient, so that's gonna happen. Critics are always out there. So if you have time to take a look at the lung scarring stats in recovered patients, can you comment on that?
On lung scarring? Is that?
Yes.
Scarring of the lungs?
Yes. Scarring of the lung statistics, I guess, for the recovered patients.
So if you mean maybe people who go into ARDS, what we're talking about, to go on the vent, they do have a lot of lung scarring. That is actually just destructive straight to the lungs. But right now, I think it's too early. We don't have data back on what long-term, changes we're going to see in folks as far as lung scarring or fibrosis. But I'll tell you, it's not something we usually see. We don't see it with other viruses. We don't see folks who've had really bad bouts of viral pneumonias. With bacterial pneumonias, we do, because they're often cavitary. It'll eat a hole in the lungs, a cavitary pneumonia that's from a bacteria. But with viruses, we generally don't see long-term lung scarring. Of course, with ARDS, that's a different picture, but it's early to tell.
Okay. Following the end of the isolation period, a large immunologically naive population will resume their normal lives. How likely do you think it is that we observe another round of infections, assuming not all cases are identified?
So at the end of the incubation period, I'm sorry, could you just repeat it one more time?
Okay. So following the end of the isolation period, a large immunologically naive population will resume their normal lives. How likely do you think it is that we observe another round of infections, assuming not all cases are identified?
Excellent point. That's an excellent point. So the idea is by slowing everything, down like we have, is we've really brought this fire, to use that analogy again, to a crawl. There'll be more herd immunity so when this isolation is lifted and people go back out into their regular lives, there'll be many more people who have immunity in the community, which will act as herd immunity. Also, it's not likely that people will, the second you lift it, people aren't going to go running around kissing each other and hugging. A lot of these behaviors that we've got now are going to stick with us. And this has been done with other epidemics, and we have history in other countries to learn from. It's not likely that we're just, once we go back, it's just going to explode again. So I think it's fairly unlikely that something bad can happen. But the whole idea is to really take the wind out of it, but to slow it down with the isolation, to allow the fire to really kind of die out.
Okay, I have the last question. I'm not sure if this will be the end, but here's the last one. Was there a new vaccine that was administered to children versus the age group over 60 that was not exposed to the same vaccines for NL63?
No, we don't have vaccines for coronaviruses. That hasn't been developed. The NL63 is so benign that we don't do anything for it. So that's not there. People ask about, the issue with vaccines. vaccines are a good ways away. I would estimate at least 2 years away to get a good vaccine. Even if you have it now, it just takes a long time to develop vaccines because you have to test it and test it and test it. The main thing for this pandemic right now is going to be avoiding isolation and the treatments that we have, and there are some others, coming. People are working really hard to throw some stuff into the mix, but the vaccines aren't going to be useful. It may even be at the end of this that we don't need vaccines. It'll die out the way SARS and MERS did. I'm not sure. I'm not saying that's what it would be, but I wouldn't buy the vaccine company stocks, is what I'm trying to say.
Okay. Well, I think we already answered this question. This was the last one. Is it true that vitamin C is helpful? And your answer was not really. Zinc, right? Zinc.
Correct. It's anecdotally, but it doesn't harm you. You can vitamin C. You can, unlike other vitamins like vitamin A, which can cause liver damage if you take too much of it. You could take a bunch of vitamin C. Anything that's taken that's excess, you will pee out. So go ahead, knock yourself out. It's not. Some people really do believe in it. So including Linus Pauling, you probably know the famous chemist. He was a huge vitamin C fanatic. So anyway.
Maybe he'll survive it and he'll let us know how it goes.
Well, he's not with us anymore.
All right, I think that was it for all of our questions. Maybe we'll give another minute or so to see if there's any more. And with that, we'll conclude this Q&A session. Thank you for your time, Dr. Melikian. That was very informative. And also thank you all of you who joined us. Very good questions that I probably didn't think about myself. There's a question from one of the participants. Any last comments from you?
No, I think if I could, again, the most important thing is if you're in a high-risk group and you're not feeling well, don't delay. Go in, get tested, and start on treatment early. Don't delay. Like I said, the longer you wait, the less effective the treatments are. Even if we had a absolutely 100% magic bullet treatment today, right now, I guarantee you, if somebody was in the stage where they're on the ventilator, your chance of survival is very low. Once it gets to there, it's about 30%. On the flip side of what I just said, keep in mind again, the chance of mortality is really specific to certain groups. So if you don't have pre-existing conditions, if you're under the age of 60, don't stay up worried too much. To worry about your parents, of course, like I am about my mom, but don't worry or but of course continue to isolate. So
yeah, so just a good practice: wash your hands, hand sanitizers, right? Disinfect all the surfaces if you can, or doors,
absolutely.
knobs, whatever, and social distancing. If you're going out in the street, make a distance with the community.
Absolutely.
All right, thank you everyone for attending this. I think we will conclude it. There's no more questions. Thank you, Dr. Melikian, for your time again. It's
my pleasure.
Very informative, and that's it.
Okay, have a good evening.
Have a good evening.